to their suffering, no easy answer to their problem. The healthcare crisis at Rosebud. 100 years ago, Rosebud was settled by the Burn Thigh or Brule tribe of the Teton Sioux. Since then, rapid economic and cultural changes have occurred, bringing many problems foreign to the native Sioux. They have suffered from diseases unknown to them before the coming of the white man. Diseases like smallpox, tuberculosis, and influenza. Their land has been sold for mineral rights and homesteading. Cultural lore has been ignored, native religion suppressed. In the midst of these staggering changes, the Indian now faces severely inadequate health care. Health care is a problem unique to the Rosebud people. However, as in other federally financed and operated Indian Health Service hospitals, at Rosebud we find a variety of unusual situations not present in most rural communities.
Every hospital that I know of in this state, or probably any other state, are, basically in the same predicament that we are. They don't have enough funding, their doctors are leaving, and everything else. So it isn't just the Rosebud Sioux people that are in this problem, and the Cheyenne people, the Oglala people, everybody else are in the same problem, and I think that something's going to have to be done.
One of the greatest problems we face is that our staff is here usually for just 2 years at a time. They were former draftees, you might say. They come in here not with the best of intentions. They come here solely because this is the nearest place they could get to their hometown, and they have no real desire to serve Indian people in any way, but only to serve out their time.
I could see the crisis that's going on there because there's people in line all through the hallways and out to the information desk, and in the lobby room it's all filled.
Well, like I say, we should have some more equipment, better equipment, like they have in Omaha. Should do surgery work here.
We do have a tremendous health crisis, have had, especially here at Rosebud, and especially in the last year, has been a real health crisis, and nobody has really paid any attention to it.
One problem is that very few people have means of transportation. Even fewer have telephones. Without cars to transport themselves or phones to call for help, minor complaints can become major illnesses. Another problem has been intensified since World War II by a cultural rebirth and reawakening. Because of this awakening, Indian people have developed rising expectations about their health care. The people of Rosebud are no longer satisfied with outmoded care, even though many still rely on herbal medicine as part of their own treatments.
Well, traditionally, Indians have been healthy. We didn't have all these diseases before, and we have a religion that is very powerful and deals with health. And so they turn to the medicine man until it's almost too late, and then they come to the hospital. And it's only been in the last 15, 20 years that Indian people began using the hospital in great numbers, and now the government hasn't met their needs, period.
It's so hard to interpret the medicine man's culture and the non-Indian culture between the two. It's a very difficult point to bring some of these out. So I think here that the problems that we have here is between the, let's not put it that the white man and the Indian, I think between the two cultures is to adjust ourselves to the basic point of the two cultures, of understanding our cultures on both sides.
I've seen some doctors come to the sweat lodge scientists. So they know just about, of course, maybe they don't know about spirits yet, but about medicines, different medicines, you know, laboratory tests. I think if a medicine man and a doctor cooperate, maybe it'll run better.
Traditional healers have reestablished themselves to preserve cultural lore and ceremonies. The medicine man is a cultural factor that is important both psychologically and physically. The degree of interaction between public health physicians and traditional healers has been small. Increased trust and understanding between these two groups would enhance medical care. Traditional medicine is a cultural necessity to many, and by combining the old with the new, effective health care is promoted and cultural values maintained. Language sometimes presents another problem between the Indian patient and the non-Indian doctor. Most Sioux speak English, but it is common under stress of injury or fear for the patient to speak and understand only the Lakota language, thus necessitating the use of an interpreter. Federally operated health care for the people of Rosebud dates from 1878, when the Indian Health Service was operated by the Bureau of Indian Affairs and staffed with military physicians. In 1915, a 32-bed hospital was built. Then, in 1955, the responsibility of health care for the Indian people was given to the Public Health Service by congressional mandate. In 1961, a new wing was added to the old hospital, raising the bed number to 46. The current unit provides an operating room, an obstetrical unit, one emergency room, small laboratory facilities, an X-ray room, pharmacy, central supply, kitchen, and an outpatient clinic. Over the years, there have been modest increases in staff, but the physical plant remains the same. Demands for service have increased. From 1961 to 1972, clinic visits increased 50%, and the average number of hospitalized patients went up 40%. It was often necessary to admit critically ill patients to beds in halls. At no time during the past decade has the physical plant, the funding, or the staffing been adequate to community needs.
Due to shortage of doctors, we have people in the waiting lines every day, some that don't get served.
This is my real concern about it. I've been there, and some went there in the morning to make appointments, and they were still there till for 5. They were still there waiting in line.
There's only one thing that they take on is they have to wait. They make a date and then they come back and they have to wait all afternoon.
Well, there's a lot of the old people come in, you know, sick, because a lot of them have to wait so long and they feel sick just waiting, you know. 3 or 4 hours they have to wait, and it makes them sick.
Even with limited resources, substantial strides have been made in continuously improving the health of the Sioux people. In the past 18 years, the life expectancy has increased from 45 to 68 years. Tuberculosis deaths have decreased 90%. Substantial decreases have been observed in infant and maternal mortality, but their incidence is still twice the national average. The position of Mr. Emil Redfish is indicative of the staffing shortage at Rosebud. A registered radiologic technologist, Mr. Redfish was trained at UCLA. His present workload, which he must accomplish alone, is to photograph, develop, review, file, and cross-reference all inpatient, outpatient, and emergency x-rays. Besides this routine work, he also takes electrocardiograms. Since the work of 4 cannot be done by one man, no matter how well qualified, filing and referencing back up. This causes more work for the Medical Records Department, which is also short-handed. Such intolerable workloads are present in all fields. Community health representatives link the health service and the Indian people by providing transportation to the hospital and by encouraging the practice of preventive medicine. Presently, Rosebud has only 12 community health representatives. These 12 must reach 7,500 Sioux, living in an area of 15,000 square miles. The focal point of this crisis hinges on the fact that more professional personnel are needed immediately, if even minimum health care is to be maintained. Over the past 15 years, the Public Health Service has relied almost exclusively on selective service obligations to recruit professional staff. When the doctor draft was ended, incentive for choosing a public career was sorely diminished. By June of 1974, the Indian Health Service of Rosebud faces the possibility of losing every one of 5 doctors because his military obligation will end. Added to this is a 50% yearly turnover in nursing personnel, and so the problems multiply. The outlook for attracting new personnel is dim. The Public Health Service expects to find it increasingly difficult to attract physicians and nurses. The reasons? A lack of competitive salary opportunities and the absence of adequate facilities in which to work.
The most immediate and pressing need is the recruitment of medical care personnel, professional personnel, doctors, nurses, and paramedical personnel, medics, laboratory people, x-ray people. Part of the difficulty is that we're limited in terms of positions available. We have personnel ceiling limits, and we simply do not have positions available for the personnel that we need. To recruit professional personnel, physicians as well as nurses, laboratory people, administrators, in a rural, isolated community is a difficult problem in itself. The single most important means by which professional personnel can be recruited to practice in this community is for there to be an effective, well-funded, staffed program with an adequate physical plant. There are many and serious problems in this community to be solved. If the tools are provided, the professional people to take on the challenge can be recruited. The present system is an externally controlled, remotely planned and funded program, and many of our problems are related to this. In any solution, it is most important, in my opinion, to develop local control and local input.
As doctors and nurses leave, the workload on those remaining becomes even greater. Morale falls, and a vicious cycle develops. Attracting physicians and nurses to an area where they are overworked, where they can't do the job they would like to do, and where they are paid substantially less than at a big city hospital is difficult. To make the situation worse, adequate housing is not available at Rosebud for a full staff, even if one could be attracted. The tribal council is now investigating the possibilities for implementing better health care. These problems at Rosebud have no easy solution. Many corrections are needed before permanent changes can be accomplished. An economic base does not exist for a self-supporting healthcare system at Rosebud. Aid and support can be sought from the federal government, state legislatures, local communities, and private organizations. At the present time, the responsibility for change lies with the tribal government and the Indian Health Service. Problem solving must be a concerted effort by the people of Rosebud and the organizations supporting change. Solutions cannot be merely proposed and accepted. Solutions must be defined, redefined, discussed, amended, supervised, and actively supported if they are to be effective.
Basically, I feel the problem is that of inadequate funding. I am aware that as far as the funding, we are, as compared to the normal hospital, American hospital, the number of patients in relation to the number of staff members, we are about 60% of what we really should be. We're going to propose that we do our own recruiting for professional people here. That's the tribe, because so far the recruiting has been done from Washington, and I think that if Indian people themselves approach professional health people, that I think that we can not only get them here, but perhaps we can relate to them, and maybe they can stay with us longer than the usual 2-year period. And then in the big area, I would like to get our people and the tribe so involved with our hospital that we create an independent operation, perhaps have an innovative, whether it be the health maintenance organization type of an operation, but I would like to have us take this and then make our hospital, as the council has already directed us, make it an area hospital whereby we can minister to not only Indians, but the area non-Indians who are living here, and thereby maybe even creating a better economic base for the hospital.
Well, the present need, of course, is, again, going back to our personnel. They are overloaded with work. And again, we go back to facilities. We don't have enough, shall we say, the right facilities to be able to do the work that is so necessary in regard to help for our people. I think that if we had adequate funding, this would help our inadequate number of personnel and also our facilities.
And I'm sure not too long ago that people were so concerned about people at Wounded Knee not getting shot. I don't think anybody can argue the fact by not registering to our Indian people, we are maybe exposing them to perhaps a slower death, but it's no different than taking them out and shooting them whenever we can't adequately minister to their health needs. And I'm sure that every day people are dying because of the fact that we don't have adequate support.
The record of the accomplished with very limited resources needs to be done. The rising expectations of the Sioux make improved health care service necessary. Only then will this Sioux athletic and cultural life as it should be in. But it is also yours and mine. If the Indian Health Service hospitals fail, the patient load on doctors and surrounding communities will increase to the point that health care to the individual patient anywhere in South Dakota will decline. A state that is last in doctor-patient ratio can ill afford to ignore this imminent possibility. The problem is ours. How we meet its challenge determines the future of every South Dakotan.